Dear friends, so we are already late. I will not spend too much time to introduce my very close Dr. Surajit SenGupta to present his physician's perspective. So he is one of us, and I don't think any one of us is not aware what he has done academically. He is, I think, one of the rarest of breed in amongst physicians having FRCP. आजकल ज़्यादा नहीं होते हैं, यहाँ पे और कोई भी नहीं है, he is the only one. So that is what he has his interest in diabetes, cardiology, and all the lifestyle related diseases. I welcome Dr. Surajit SenGupta, please.
Thank you very much, sir, for a very kind introduction. Witness this night's gaming, and thank you, Dr. Chauhan and the entire group for inviting me, and Amish, Vora, and yeah. So, about a week ago, Dr. Chauhan and Dr. Amish Vora just, kind of thought of this kind of a procedure to do a bit of a rallying for me. So, why I sort of said yes to that was because the basic premise was such that it was taking me back to our college days of good old clinical examination, sorting out a differential diagnosis, and looking at clinical things and being taught by masterly teachers. That was the first incentive, and true to their word, Dr. Vora and Dr. Chauhan, they are still not revealed to me what the case is. So I am supposed to be dwelling on the differential diagnosis and possible symptomatology of a case with bony pain with an ESR of 100, which I will be coming to subsequently. The second incentive was obviously Amish promising me a bottle of his favorite single malt whiskey. Yeah. So for reasons of discussion, as I was thinking about it on the way, I would just be dissociating the two features for the time being and just think of it from the perspective of a physician. Keep the 100 ml per hour ESR separate and the bony presentation that we are. So,
can we have some recipients there, please? I want all of you to sit down. We will serve you on the table. Naresh, get everyone seated and serve them on the table. Saurabh, Manish, please. Can I ask you? Please sit down. It's your presentation, man. Respect it. I don't want anyone to stand there.
Can we have Dr. Upadhyay also here, please?
Dr. Upadhyay?
Yeah. And maybe Dr. Chauhan as well?
Yeah, I'm coming.
So when we look at bony pains as terms of presentation, we have to be very sure what exactly we are looking at. We are not looking at arthritis or arthralgia, that is joint pains. Anybody who has gotten hurt on the shin or on the knee, periosteum being the most pain sensitive organ, knows what an acute excruciating bony pain is, and we are talking about a very gnawing, deep inside, nagging kind of a pain which is going to be there, whether we are talking about a generalized pattern which Amish and everybody will be talking about during the course of the presentation, or a localized kind of a pattern limited to certain parts of the body. Also, we have to be sure that whether we are looking at general myalgias and a general term that all doctors use, musculoskeletal pain. Also, we have patients who come up with this often cliche kind of, terminology saying we suffer from rheumatism. So what exactly we are looking at, that we have to differentiate on the basis of history. On the basis of history, again, we have to see what the age categorization is. The sex of the patient, obviously, we know that certain diseases have preponderance commensurate with age and sex. And then when we are looking at the basic presentations of bony pain, and we are by and large sure that we are looking at bony pain, A differential diagnosis, if we, for the sake of diagnosis, I know we are talking about hope, so obviously oncology will be the prime thing. But in terms of bony pain, we look at trauma, fractures, inflammations, blood trauma, etc. Then we go on to diseases of like osteoporosis, osteogenesis imperfecta. We look at osteonecrosis, osteomalacia, which can cause nagging bony pains all over. You look at malignancies, right? We have then things like polymyalgia rheumatica, we have Parkinsonism, we have diabetes, we have hypothyroidism, which can all cause some kind of bony pains, general amount of fatigue, weakness, which also falls into the differential diagnosis of the basic presentations of the some of the oncology problems that we look at. We also have diseases like not very common out yet. When you read up, things like Lyme disease and scurvy, etc., which can cause generalized bony pains. So and also things like inborn errors of metabolism like homocystinuria, etc., which again are causes of bony pains. We are not really looking at the sickle cell anemia crisis kind of pain, which is a very acute. If somebody has seen a patient in sickle cell crisis, only he would know and appreciate the kind of presentation that is. So once we have by and large ruled out arthralgia, arthritis, general pain, patients with depression can also come up with general kind of fatigue and misdemeanor about bony pains or generalized body ache, etc. So once we have ruled this out, what are the symptoms that we are looking at? Something which would lead us to a kind of a diagnosis that we want. So we look at things like fever, we look at night sweats, chills, we look at fatigability, breathing problems, bruisability, bleeding. We look at blurry vision, thirst, which can be, because of hyperviscosity syndromes, because of some malignancies, which would be, I think, a point of discussion today. We look at things like weight loss, lethargy, look at, people complain of heaviness in the abdomen. Believe me, people who have lymphadenopathy and splenomegaly often have very undescribable heaviness in the abdomen. And only when you investigate further do you get to know. And then when you are trying to pinpoint a particular clinical diagnosis, then you see things like, when you think about hypothyroidism, diabetes, both type 1, type 2, I'm not getting into the other types of diabetes. Things like osteogenesis imperfecta, etc. When you're looking at, once you've kind of channelized onto what you're trying to see and locate, then you look at the blue sclera of that person. Homocystinuria, you look at B6 levels, etc., and then try and see, because there are patients who are going to present with generalized body ache in which simple B6 supplementation would be sufficient. Paget's disease. And then you come in again. No, I'm just finishing off. Paget's disease, etc. And obviously the other metabolic disorders. So once we have gone through this, have drawn up a differential diagnosis, gone through the symptomatology, and then you advise investigations to by and large come to a reasonable differential diagnosis and then take the things forward. So I hand it over to Dr. Amish.
Thank you, sir. So, before we go on the case, there are two things which Chauhan sir and I, when we envisaged this CME, what we thought was that everybody should be included. Sorry, sir, please.
Yeah, let me introduce Dr. Amish Vora. He is MD/DM, Medical Oncology from AIMS and ex-associate professor from Tata Memorial, Mumbai. Co-founder of the Hope Cancer Center. His special interests are in lymphoma, breast, ovary cancer and geriatric oncology. Welcome, Dr. Vishwara.
Thank you, sir.
Can we give a big hand to Dr. and also to Dr. Amit Upadhyay. He is still to be introduced. To Madam Apni.
Sir.
Can you stand, Madam Apni? Dr. Sonali. Yes. And we'll give a minute in the end to Dr. Amish Vora to introduce his entire team. Once they have done the show.
Sir, if allow me to just finish off, since we have started the introduction, I'll finish off in 2 minutes.
Yeah, please.
Okay, perfect. So every time, and first of all, thank you so much for making me part of all of you. And I feel now whenever Chauhan sir calls me, he's calling me home. That is how I feel it. But today, I felt that it is not me, it is the hope which is presenting. And there are various facets of hope. Hope may be a small center, but we have tried to cover all the aspects of oncology care. That is what I wanted to say. So we have hematologist and oncologist, Dr. Amit Upadhyay. We have pain management doctors, Dr. Sonali Chatterjee and Dr. Upadhyay Purana. We have surgeons who are our colleagues, Dr. Vivek Gupta and Dr. Rudra. We have a radiation oncologist who could not come, but Dr. Ritesh is there. We have, I have first time taken liberty without asking Chauhan sir about one of our nurses, Sanish. Sanish is from day one, and if I start speaking about him, it will be half an hour, so I don't want to speak much about him. We have our staff, again, Promila you all have seen, and Yash, who is from day one in Hope. We have one of the special, and I thank Chauhan sir for that, and I thank the forum for that. I have got one of the best person in Delhi, Dr. S.K. Podar. Dr. S.K. Podar, after a lot of persuasion, I have requested sir to be Director of Medical Affairs for Hope amongst many of his things. Sir, Dr. Vishu and Vipul have not come as yet. I'm sure they will come in the end. But they provide all the lab services all across this thing. Mahajan Imaging for all radiology services. We have one special person, Mohak. Mohak has been from day one. फार्मेसी का कोई भी ड्रग बोलो, आधे घंटे में अगर ये नहीं पहुंचाएगा तो पैसा नहीं लेगा. We have partners 24/7. Please come, Ankit, Dr. Ankit. They provide all the home care services for all of our patients. We have molecular oncology partner called Dr. Amit Verma, who is trained from MD Anderson Cancer Institute, Houston, Texas. And last but not the least, many of you have met my partner, Mr. Aditya Talwar. Mr. Aditya Talwar has decided to move on, and his shares are taken over by my wife, Avni Vora. So Avni and me are now 50% owners of Hope. Why I wanted to introduce this is that कि मैं आगे हमेशा माइक पे बोलता हूँ, but without these people I am nothing today. So I wanted to say that the entire Hope family, and again as I say, Chauhan sir, आपका जितना thank मैं कम करूँ उतना अच्छा है, and this forum, and we sincerely say that any patient with cancer, as you can see, from start to end, we are equipped to give the solution. Now it is, sort of how we work together, is how you take the entire Hope as the group of this group, part of this group, is up to you all. Thank you so much.
Dr. Amit, if I am associated with Hope Center, I expect that you, and I sincerely feel that you all are associated. So you all are advisors for Hope Center. That is my expectation. And you all should support Hope Oncology Center.
Thank you.
I think we need to move to the presentation.
Yes, we will start.
It hasn't gone the ideal way. Dr. Amish Vora was to start with the case, but there was a lot of confusion. And I think it is absolutely in the right context that Dr. SenGupta has set the tone of a case presenting with bony pains, fatigue, and an ESR of more than 100. And Dr. Amish will now take you through the case, and then we proceed.
Thank you, sir. Thank you, Chauhan sir. So straight away we'll go to the case, and Dr. SenGupta sir has set the stage. 70-year-old male, normotensive, non-diabetic. Patient said, मैंने last sugar अपना 4 साल पहले करवाया था, उसके बाद नहीं करवाया. Backache since March 2022. X-ray was done, which was normal, but the pain persisted. Orthopedic doctor advised MRI spine. There was a near complete collapse of L2 vertebral body. multiple punctate lesions. Patient was on painkiller without much of help. Meanwhile, patient had mature cataract and went to ophthalmologist. And ophthalmologist said, "कि आपका surgery immediately करना पड़ेगा." So routine investigations before cataract surgery were done, and this was the CBC. For people who can't read, why I have kept this, because I want to say this is a real case what we are dealing with. Hemoglobin of 8.6 in a 70-year-old fit middle class Delhi from Sikh community. 8.6, TLC was 5.6, differentials were all okay, platelet count normal, and ESR was 94. Okay. KFP, if you see, sodium was 126, total protein 9.5, albumin 3.3, globulin 6.2. So far what do we have? 70-year-old male, bony pains, anemia, ESR, 94. KFT is abnormal as you can see, and MRI L5 vertebral collapse, multiple punctate lesions. So differential diagnosis. Dr. SenGupta, you have said multiple different aspects. In this particular patient, what could be your 3 to 4 differences?
So if I'm looking at it with this kind of bony pains, then classically if you're looking at multiple punctate lesions, multiple myeloma should be first on the list. Then you have to look at other things also, like, I mean, not an oncologist, but whether you're looking I don't know if MGUS or plasmacytoma would be presenting like this.
We will, Amit will come and clarify that.
Yeah.
But apart from myeloma and buckus, from the non-oncological perspective, what would be your differentials?
So it could be osteoporosis looking at vertebral collapse,
Correct.
multiple punctate lesions as I've already said. Anemia, but with the kind of protein and the raised globulin, so we are obviously looking at a raised globulin spike. Whether it is an M protein spike, that needs to be known on a plasma, the electrophoresis spectrum.
Right. Tulsi sir, reverse AG ratio. As you can see, total protein is 9.5 with globulin 6.2 and albumin 3.3 and anemia of 8.6 in a healthy guy. What would be your differential, sir?
I would probably stick with multiple myeloma.
You will stick with multiple. Sir, if we would not have been presenting and some endocrinologists would be presenting, what would be your differential, sir?
Endocrinologist.
Endocrinologist.
Multiple endocrine syndrome. Renal osteodystrophy can also present.
Sir, I'm asking, in your clinic, ESR high, anemia and body pains is a very common thing, right? So the point is that this patient went for cataract surgery. If he would not have gone for cataract surgery, probably L5 vertebrals में अगर orthopedic में अपना कुछ spine का surgery कर दिया होता, and the patient would have moved on.
Any cancer with METs can also present like this.
Any cancer with METs also can present like that, right? Anyone
Any
any
cancer with METs, that's
Man.
MEN, type 1, type 2? Type 2, okay. I see men either type 1 or type 2 1 in 5 years. And I see only cancer, nothing else. So, I thought it is a very, very common presentation. Any other reason for reverse AG ratio? There are so many reasons for reverse AG ratio. Anemia can be so common in community today. Reverse AG ratio, so many of liver disorders we have reverse AG ratio. Nephrotic syndrome can be one of the things, correct? Right. So, I will just add on, as sir mentioned about multiple myeloma first, Tulsi sir mentioned about multiple myeloma first. So, this is the abnormal M spike. Okay. If you remove this, this is a normal protein electrophoresis. But if you see the gamma region, you have 4.7 grams per DL of the M spike. At this point of time, is it enough to say patient is suffering from multiple myeloma?
No.
Was my question too leading?
The plasma cell count also, you need to see bony lesions, you need to see the M spike, then come to a reasonable diagnosis. And renal.
So M spike is positive.
Yeah, and
Ng ratio is reversed.
you also need to look at hypercalcemia.
9.2. 9.2 is. So assuming all the report what we have said is normal.
Yeah, the classical crack symptoms of MS, whatever.
Crack syndrome is what Dr. SenGupta is mentioning about crack, CRAB, creatinine, calcium, renal, that is creatinine, anemia and bone. Sir, anemia है, bone है, crack में दो तो हो गए और M spike हो गया. Everything else is normal. Do we still call it multiple myeloma? Plasma cell I say normal.
Sir, if M protein is present there, this
M protein is present, anemia is present, bony lesions are present.
multiple myeloma.
Tulsi sir says multiple myeloma. How many of you agree? Sir, Dr. Amit Upadhyay is the judge of it finally. I'll call him for that. So how many of you agree it is multiple myeloma by now? Okay, perfect, fine. So Amit, before I call you, just yes or no, would you agree this is multiple myeloma by now?
I mean, smoldering multiple myeloma doesn't have bony lesions all the time.
Correct.
So that could be there. Plasma cell leukemia is again no bony lesions which are there. Again, if you're looking at MGUS, MGUS, but out there the protein spike is lesser.
I'll give you one more report, sir. Free kappa and lambda, where lambda is 126 and kappa is 25.36.
Can it be parathyroid?
Parathyroid. Parashar sir बताएंगे sir parathyroid है या नहीं? He is the
Can it be parathyroid lesion?
parathyroid. What sir? Parathyroid tumor, parathyroid abnormality, hyperparathyroidism. Hyperparathyroidism. Hyperparathyroidism sir kappa lambda ratio ऐसा होगा? नहीं होगा. Okay. Punctate lesions would be there. Calcium can be abnormal. Protein can be abnormal. But M spike and kappa lambda ratio. So. Sorry, somebody was saying. Sir, again, what you are saying is right, but it is partially right, and I would again invite for Amit for that. If suppose if you see lambda versus kappa, normally the ratio sir is kappa versus lambda, but when you look at the ratio, some people say whichever is higher, lambda upon kappa. If you see lambda upon kappa, then this ratio is 6. Okay. If kappa also would have been say 80 and lambda 126, what is it that commonly you would look at? Kappa lambda ratio is say 1.3, but kappa is 86 and lambda is 126. What is the first thing you would look at? Extremely common. In CKD, chronic renal disease, it is extremely common for both kappa and lambda to be high, and that's why the ratio is very important about that. So finally, I said bone marrow is normal, but this is the bone marrow of this patient, 45% plasma cells this patient has. They are abnormal and biopsy also the same. So I would invite Dr. Amit Upadhyay to talk about the diagnostic criteria of multiple myeloma versus smoldering myeloma.
Good evening, everybody. Now, as Dr. Vora has already introduced the topic and the patient and the given clinical scenario, so in the background of this, I will just highlight few differences that what is actually Amgas, SMM versus symptomatic myeloma, which is called normally we say multiple myeloma. And many times we have seen patients who are actually not myeloma but being treated for myeloma. So it is important to be that we should be knowing that nobody will be either under-treated or over-treated. So it starts with Amgas. Amgas is actually quite common.
in patients more than 55 years of age, 5% of in normal population they can have a Amish spike. So it is pretty common. Just to get an Amish spike doesn't mean myeloma. We have to see the other clinical features. Then second stage comes is the smoldering myeloma. So when we say smoldering, that means it is threatening to become symptomatic. So the Amish spike is increasing gradually. Urinary BJP, again the proteins in the body they are increasing more than 500 mg per 24 hours. And the bone marrow plasma cells and clonal plasma cells, that means one particular clone is driving the increase in plasma cells. They are more than 59%. And one very important thing, we all know about CRAB criteria that Dr. Vora also mentioned, but there are three other criteria which are called MDE or the myeloma defining events. And these are again very important. They are as good, they are as important as the CRAB criteria. So what are these? There are three. One, more than one skeletal lesion on MRI or PET scan. Second is the bone marrow plasma cell level of more than 60%. Third, as Dr. Vora mentioned about the FLC ratio, the light chain ratio, whether kappa lambda, it should be more than 100 by 1. If either of these present, it is considered as myeloma. If none of these is present, it will qualify as a SMM, smoldering myeloma. So coming back to the main thing, the multiple myeloma. So first and foremost important criteria is that we
have some silence at the back, please, once again.
So we have to show that clonality, that means the bone marrow is showing more than 10% plasma cells, or there is evidence of extramedullary plasmacytoma. So we have a biopsy proven plasmacytoma, fine. Or we have to show more than 10% of plasma cells in the bone marrow. That's an important criteria, and that is first criteria. And so that means we have to document in the bone marrow that plasma cells are more than 10%, or there is a plasmacytoma. Along with that, any one or more than one, because we have to understand that myeloma can be very heterogeneous in presentation or in the clinical course. And for example, in normal myeloma cells, when it was diagnosed, they are carrying more than 4,000 mutations. So there can be very variable presentations. So whether we are discussing about the CRAB criteria, that hypercalcemia can be there, renal insufficiency can be there, anemia can be there, or the bony lesions can be there. Along with that, we have the three events which I mentioned, that FDV PET showing more than one skeletal lesion, or FLC ratio is more than 100 by 1, or there is plasma cells in bone marrow more than 60%. These are myeloma defining events. So whether we are getting 1, 2, 3 doesn't matter. Even an Amish spike, a bone marrow which is showing more than 10% of plasma cells, or any of them can be myeloma. But one important caveat is there, that when we say anemia is very common because myeloma usually comes in elderly. In elderly, anemia can be of very varied presentation. So the anemia is not, let's say if there is iron deficiency, then it will not be qualified as a myeloma related event. So anemia because of myeloma, unexplained anemia lesion. Same for renal insufficiency, otherwise every CKD patient can have a scheme. So when we are not having any other reason for that, then these three are the important things. Bone marrow, second is Amish spike, and third is either of these criteria. So they qualified as in myeloma. Let me tell you about a simple case which we see 2 days back. A lady somewhere around 75 years of age. She was having low backache. Got an MRI done. On an MRI, there were 3-4 little lesions referred to as a suspected myeloma. But all the parameters, there was no spike, FLC ratio normal, immunoglobulin level normal. We got a PET scan done. Turned out that she was having breast cancer. So little lesions are not pathognomic of myeloma. They can be there in breast cancer, lung cancer, or like. So it is important to evaluate all these things. Only then we can label that one as having myeloma and then require treatment. coming back to the case. But
Thank you, Amit. So as Amit said and sir, as you mentioned, if the kappa lambda ratio is more than 100, it alone qualifies for myeloma. But that does not mean that the kappa lambda ratio of 40 or 30 does not qualify for myeloma. There has to be other factors also present. Am I right, Amit? So we move to that. Treatment and prognosis. So myeloma was confirmed. Now this particular patient kept telling us कि मुझे पेन फ्री तो करो, आप इतनी सारी टेस्ट करा रहे हो, बैकेज 1 साल से मुझे बैकेज चल रहा है, आज तक किसी ने इसको ठीक नहीं किया, मैं खड़ा होता हूँ तो मुझे चेस्ट पे जोरदार जोश पड़ता है, जो he had a sternum lesion also by then. He said, मुझे पेन फ्री तो करो. So for that, I invite Dr. Sonali. She is the pain expert at Hope. Apart from managing the entire daycare, she has done her course of pain and palliative management from AIMS also and from Cardiff University also. Dr. Sonali.
Myeloma is generally associated with bone pain, and in myeloma not only the bone pain is the problem, it's a problem of skeletal ligaments because the bones are weak and you can have a fracture easily, and the skeletal ligaments can occur beside myeloma in other cancers with bone metastasis. And there is an emergency which is called spinal cord compression. If we think that there is a spinal cord compression, we have to act immediately. And of course, myeloma is associated with hypercalcemia. And since it is an immunocompromised state, we see a lot of herpes zoster, and herpes zoster also comes with a lot of pain. You have to feel it. So, as we know, mild to moderate pains we can manage with the acetaminophen and the NSAIDs. But in myeloma, we have to be careful regarding the kidney functions. In most of the cases, the kidney functions are also deteriorated. So the dose, we need to think about what kind of dose we are giving. And in all this works, we are giving a combination therapy rather than giving only one kind of therapy. So if we start on acetaminophen, we have to see whether liver function is alright or not, and then we start on NSAIDs. And if they are not controlling pain nicely, then we start opioids. But if we combine 3 of them, we will see that opioid doesn't go, the dose doesn't go a lot. Though opioid doesn't have any ceiling effect, but we don't want to have complications because of opioid. So 3 things we should try to combine and give if necessary. If it is controlled by acetaminophen, then there is no need to give anything. But if it is not, generally it is not, so we add NSAIDs and then opioids. And another thing which works out here is 2 osteoclastic inhibitors which we start, and that is bisphosphonates and denosumab. They work very well for myeloma pain. It reduces the hypercalcemia too, and it helps in relieving the pain. And of course, glucocorticoids works very well in myeloma because glucocorticoid anyway is a part of myeloma treatment. And glucocorticoid works very well for bone pain, but we have to be very careful if we are giving NSAIDs and glucocorticoids together, because we have to think about this, the peptic ulcer issues. And also, when they are radiating pain, then we prescribe anti-epileptics or antidepressant along with this. And tramadol is a weak opioid, but tramadol works very well in neuropathic pain. I think I have covered most of it, but other than this, adjuvants like local nerve block, which works very well in the rib involvements, and there is radiation therapy like SBRT, which works very well if the pain is localized in 1 or 2 areas. And of course, if there is an impending fracture we see in the scan, then surgical intervention may be required, and radionuclide therapy for disseminated disease.
So Dr. Sonali Chatterjee's contract in Hope says that if any patient after 2 of her consultations are not paid free, she doesn't get paid for that month. And it has never happened that she has gone without any pay. So you can imagine that the idea of telling this is that today it is a crime if any patient, no matter whatever is the disease, has pain to suffer. And we have loads and loads of medicine where at least if we can't do much about the disease, we can give a good quality of life to the patient and make that patient pain. So that is what Dr. Sonali did, and the patient said, I am pain free. Chauhan sir ko dekh ke yaad aaya. Today Chauhan sir and we have discussed and we are doing this particular sort of a different type of thing where we are involving many speakers. Please give your feedback that इसमें कुछ अच्छा लगा, नहीं तो again we can go back to our this thing routine. So patient is pain free. Patient asks us, is my disease curable? And how long am I going to live? So I would like to ask every one of you, multiple myeloma, is it curable? Not curable. Curable, not curable. How many of you say not curable? How many of you say curable? Okay. विशु, तुम लेट आए हो, तुम्हारा नाम अनाउंस करने के बाद भी नहीं आए हो. मल्टीपल माइलोमा क्योरेबल है या अनक्योरेबल? क्योरेबल है. अमित, फाइनल वर्ड. मल्टीपल माइलोमा क्योरेबल, नॉट क्योरेबल?
Incurable. Why sir?
There is always a hope.
There is always a hope, and for that I request everybody to come inside hope. For that, multiple myeloma by theoretical possibility is curable, but that theoretical possibility is not practically achievable. Allogenic bone marrow transplant is the only thing which cures 25% of multiple myeloma, but transplant-related mortality, allogenic, I am talking of not autologous, is 40%. So 40% people are going to die because of transplant and 25% going to get cured doesn't make any sense. Minus that, multiple myeloma is not curable. Okay. So the main treatment, and this is the something which I feel I would request everybody to go through this. People with myeloma live minimum for 3 years and maximum for 30 years. This is the median survival. Okay, a 70-year-old person living for 13 years lives for 83 years. CKD without kidney transplant, median survival is 4.6 years. COPD requiring bypass support, median survival is 5.6 years. Okay. CHF minus heart transplant, NYHA grade 4 is 3.6 years. Multiple myeloma, even stage 3, people can live up to 30 years. But लोगों की आंखों में क्या होता है? यार incurable disease है, क्या करना है? So that is something which I feel we need to understand. I would invite Dr. Amit again for the treatment for multiple myeloma. Amit, now since patient is pain free, patient is diagnosed of multiple myeloma, 70 years old gentleman, how will you proceed with the treatment?
So coming back to treatment, in multiple myeloma, normally the worldwide standard is the first thing we have to see is the patient whether it is transplant eligible or not eligible. That means when we say transplanting myeloma, we are usually referring to autologous transplant, not the allogenic one. This is the standard of care and this is the backbone of all the myeloma related guidelines. So first we have to categorize the patient. But now as our patient is 70-year-old and the general convention is that more than 65 we usually tend to avoid bone marrow because the toxicity keeps on increasing. So at a 70-year-old age, definitely we are not looking at that we are going to offer transplant to this patient. So we go for non-transplant also. So we have a very well-defined protocol. Usually there are 3 drugs which are given, bortezomib, lenalidomide and dexamethasone. This is the upfront treatment. Of course, sometimes the conditions can vary that somebody is having severe renal dysfunction, we might avoid lenalidomide for 1 or 2 cycles. But this is the backbone of the most of the initial cycles. Then usually what we see is the patient responded well for a few years, maybe 2 years, 3 years or 4 years, something like that. and then again the disease comes back. So then we have to go for other alternatives which are there. Nowadays we have got few very excellent monoclonal antibodies. Daratumumab is available in India and it is a really wonderful agent. Very less toxicity and it has actually changed the overall landscape of myeloma treatment. Other than that, dexamethasone alone is a very good anti-myeloma agent to begin with. In fact, many times if the patient is having severe or a huge plasma cell burden to begin with, we usually give only one cycle of dexamethasone, that is high dose, 40 mg dexamethasone for 4 days, something like that, to stabilize the disease and then go for treatment. But these medicines are usually the backbone. Other medicines which are available are carfilzomib, pomalidomide, ixazomib, and normally we don't use chemotherapy drugs. The traditional chemotherapy drugs like cisplatin, doxorubicin, these are the variants which we have been using in fact almost 20 years back. But nowadays it's all about monoclonal antibodies or the targeted treatment. And the results are much better than that. In fact, as Dr. Vora also mentioned, in low risk or standard risk, we can expect a life of somewhere around 8 to 11 years now with all these medications. And that too with a very good quality of life. So treatment phases are two. Here it is also there. Initially we have to decrease the burden to undetectable levels. That means the Amish spike should be 0. That is the goal of treatment. And then FLC ratio normalization, bone marrow, plasma cells ratio normal. These are the goals of treatment. And then you put the patient on maintenance, usually lifelong or at least for 3 years. The option can be lenalidomide or pomalidomide or bortezomib or even sometimes cyclophosphamide.
थैंक यू डॉक्टर अमित। डॉक्टर सेनगुप्ता मेरे बाजू में बैठे थे, बहुत बातें करा रहे थे मेरे से। मैंने सर को रिक्वेस्ट किया, सर इतनी बातें मत कराओ। The one very important sentence which he said and which is so important in oncology, he said, Amish, सोच अगर 60 years का बंदा है, माइलोमा होता है, आप उसको 10 साल देते हो जीने के लिए, वो अपनी सारी रिस्पॉन्सिबिलिटी 10 साल में पूरा करता है, उससे अच्छा क्या चाहिए? And sir, hats off to you for this sentence. ये एक sentence में सबको समझाने की कोशिश करता हूँ, and today you have done the wonders by understanding that. The whole idea, New England Journal of Medicine, editor-in-chief had pancreatic cancer 10 years back. And he wrote one-page editorial in the next article. He said, looks like cancer is the best way to die. We will not debate on that. I just leave on that thought. Whenever Chauhan sir next time gives me an opportunity, we will take that topic at that time. We will move on this. So as Dr. Amit Upadhyay mentioned, we started this patient and now we need Dr. Chauhan here. He said he's just coming into me. Chauhan sir? Okay. So, multiple myeloma, as I said, is we transplant and non-transplant. Now, when we say that multiple myeloma is not curable, then what is the role of bone marrow transplant? Allogenic bone marrow transplant we don't do. There is something called as autologous bone marrow transplant. And Dr. SenGupta asked me, what is autologous bone marrow transplant? In a simple term, patient has myeloma cells inside the blood, which goes in the bone marrow or comes from bone marrow, we don't know. In that particular scenario, what we do is, we give chemotherapy to the patient, myeloma becomes undetectable in the blood. We give growth factor to the patient so that the stem cells from bone marrow come to peripheral blood. जैसे डायलिसिस फिल्टर होता है, वैसे बोन मैरो का स्टेम सेल्स का फिल्टर होता है. You do a plasmapheresis, collect the bone marrow stem cells, freeze them in -90° temperature. After that, we give them such high dose chemotherapy नॉर्मल अबनॉर्मल जो भी विसिनिटी में दिखता है सारे के सारे सेल्स मर जाते हैं। इफ ऑल सेल्स डाई व्हाट विल हैपन नेक्स्ट? देन कम्स -90 डिग्री टेम्परेचर में जो थॉ उसको थॉ करके बॉडी में आप दे दो, द नॉर्मल सेल्स रिकंस्टिट्यूट without bone marrow cells. Okay, so this is the bone marrow transplant. It adds on 2.5 to 3 years more of life. If somebody with myeloma is going to live for 10 years, and if you do the bone marrow transplant, 2 to 3 more years are added with a very good quality of life. So coming back to the case, patient is started on bortezomib, lenalidomide and dexamethasone.
Can I ask a question? How much does the or later?
Sir, later. So patient bortezomib is subcutaneous injection. चमड़ी के नीचे लगता है, घर पे आके भी लोग लगा जाते हैं. Lenalidomide is an oral tablet. Dexamethasone can be oral or IV. So can you detect multiple myeloma treatment first line today? Can be done at home also. This particular patient is started on the treatment. Second week of treatment, patient's son calls us. Chauhan sir, please. Sir, father's sugar is 440. He was never a diabetic. Sir, कौन सी दवाई दे दी मेरा बाप को डायबिटिक बना दिया? And this happens every time. This is the language which patients talk. I'm not making up. And remember the history. Last sugar check was 4 years back. And HbA1c before starting chemo we did was 6.6. The idea of requesting Chauhan sir to prepare this was, जो मैंने देखा है, you people, many of you know diabetes management much better than any of us. But cancer का केस में ना many of the physicians refuse to take the patient. So here patient has sugar of 440 and I refer back the patient to Dr. Chauhan. And how will Dr. Chauhan manage this patient hyperglycemia on this treatment? When you get a patient of diabetes or a hyperglycemia, please remember myeloma में it is transient. 4-5 दिन ऐसे आएंगे जिसमें hypoglycemia होगी. I want that to be covered. That is the bottom line of myeloma hyperglycemia treatment. Okay.
So I think there are two things that Dr. Amish Vora talked at this time. When we use dexamethasone, our patients are likely to go into states when they have blood sugars more than 400 and even 500. These are transitory things. They do not mean that the patient is likely to go into ketosis. Two things always remember. If your patient is a type 2 diabetic, non-diabetic, of multiple myeloma, with dexamethasone therapy by Dr. Amish Vora and his team, very unlikely that we will go into ketosis with the use of steroids. So what are you going to do? If you want to settle with short-acting drugs, then the drug of choice is not limepiride, the drug of choice is glycoside. What is the maximum dose? 240 milligram. What is the maximum dose you use? In the morning or in the evening? Morning. In the morning. And you use a smaller dose in the evening. Right? Now, if you were to use a basal insulin to control this blood sugar, when would you rather like to use a basal insulin in the night or in the morning? In the morning. Shift that basal insulin to the morning. Do that. And if you are still not able to get to the targets, use basal bolus. Okay? But if your sugars are more than 200 milligram any time of the day, how many times do you require monitoring with CBG, capillary blood glucose? 4 times. 4 times a day. Okay? But do not use a long-acting oral hypoglycemia.
Well, let me take the opportunity to set the ball rolling. As was presented by Dr. Chauhan on the group, this time it will be a case-based study and he had given a hint that a person with bony pain, with high ESR, fatigue. So, despite my efforts to find anything other than multiple myeloma, I failed every time. It was so many different parts. It could be some malignancy of other kind, maybe some leukemia, it could be some other lymphoma, maybe some inflammatory diseases.
Even tuberculosis.
Yeah.
You should not forget what time. We can
Yeah.
get raised ESR. I can
So
have
what are other possibilities which could equally match if they are, but if we could know as we saw the globulin levels high than the albumin, it was one of the selling points, and calcium of course.
There are two, three things. Anemia can be very common as an initial presentation for different conditions. Same with globulin levels raised in many things, any inflammatory condition, in chronic liver disorder, kidney diseases, any vasculitis, we can have this. But a very important point is calcium. If we are getting a raised calcium, that usually none of the chronic disease will be having, except maybe sarcoidosis sometimes can have that, but these are pretty rare. In all other things like port spine or wherever, we usually tend to see lower side calcium. So if the calcium level is on the higher side, but let me tell you, we do see sometimes patients who are having CKD and then go on to develop myeloma. So we have anemia because of CKD, we have renal failure because of CKD, but it is the calcium which teaches the diagnosis.
My just half question is, most of the patients having seen that patient is having bone pain, they will give vitamin D. So what is in this case? Do you think vitamin D is indicated, or if given, is it bad?
Not initially, but we tend to give both vitamin D as well as calcium because the bones are lost then and we have to replenish. So calcium as well as vitamin D both will be required, but not in the initial. Once we have stabilized the hypercalcemia, only then.
Absolutely. Sir, question?
सर आइए इधर आइए ना कोई बात नहीं बोले नहीं Sir, please, go ahead. So, sir, take a mic.
Can I give a presentation of a case, Dr. Chauhan?
Sir, go ahead.
Okay. So friends, we had a 50-year-old female who was obese. Where is Dr.
Sir, go ahead.
So she had myalgia, polyarthria, her biomarkers, ESR and CRP were raised, and a diagnosis of PMR was made. And as one of our physician friends recommended, diagnosed as PMR, recommended steroids and methotrexate. Now, this was fallacious. See, this was not a case of PMR, but the markers, the ESR and the CRP raised because of obesity. So friends, what I need you to understand is that we don't go for lab results. We need to treat the patient per se. Would you like to agree with me? Dr. SenGupta? Yeah. Hold on. Let him answer. Good. Yes. say?
Lab marks are just to guide you, basically to see in totality whatever is happening and then decide accordingly. Just because somebody has a race here doesn't mean that you start blocking that particular parameter.
Okay, let me ask.
See totality.
Okay, let me ask Dr. Amit Vora. Dr. Vora, that was a wonderful, very crisp presentation. You hardly took 10 minutes. And what was the presentation? So tell us a little about the FDA which has approved the gene therapy called the CAR-T cell therapy. Friends, do you understand what a CAR-T cell therapy is? Dr. Vora? No? Tell us what a CAR-T cell therapy is. Okay, Dr. Amit. Yeah, Dr. Amit.
So, CAR-T stands for chimeric antigen receptor T cell therapy. What happens is, take patients' blood and isolate the T lymphocytes which are of significance. Multiply them in the cells in vitro in the multiples of millions of cells. Tag them with, say, for example, if myeloma cells is anti-CD38 antibodies, tag them and infuse them in the patient's blood. What happens is that they go and home in at the cells which are required to be destroyed, and they identify as and they get destroyed. CAR-T cell therapy, first time it was approved by US FDA in acute myeloid leukemia, then multiple myeloma, then acute lymphocytic leukemia, then non-lymphoma.
My second question to you, Dr. Amit, would be regarding the genetic testing, which has been a game changer. The immunotherapy combined with water therapy, which can reverse the cancer resistance to immunotherapy. This was published recently in the Journal of Immunology. Just to talk on that.
Sir, therapy is a very, very interesting concept. 2019, there are two physiologists who got the Nobel Prize for introducing immunotherapy in the world. It's a very, very interesting concept. Whenever the cancer cells in the body, they want to multiply, they have to evade the immune surveillance of the body. आपके बॉडी में, मेरे बॉडी में, अमित के बॉडी में कैंसर सेल्स रोज होते हैं, but immune cells attack those cancer cells and destroy them. When the cancer develops, the cancer cells handshake with immunity of the body and say, हम दोनों तो दोस्त हैं, मेरे को पनपने दे. What does immunotherapy do? Immunotherapy breaks that handshake between immunity of the body and cancer cells, and as a result, immunity of the body, they awake and they say, oh, these cancer cells are foreign cells, I have to destroy them. That is how the immunotherapy works. That is what it's like.
I was referring to what is intervene, which is a molecule which would probably, abolish the resistance to immunotherapy. This was published recently in the Journal of Immunology.
Sir, there are a lot of research happening in the field of immunotherapy, and there are more exciting days to come.
Thank you, sir.
Dr. Parashar wanted to ask some question.
Sir, I wanted to ask simply, the basic device today was, what is the bone pain? Now patients come with various type of pains. So how do we differentiate that this pain is a bone pain rather than anything else? And second similar question is, where do you store these things at 90 degrees, minus 90 degrees or whatever? Where do you store it? Where do you have this storehouse? Thank you.
There are few facilities in the NCR, situated in Gurgaon and Delhi, and most of the hospitals have outsourced their storage services to them. They are deep freezer, they are catering up to minus 180 degrees. So we are keeping those safe from between temperature between minus 80 to minus 180, and then we can order them whenever we need them. So even at our center we are outsourced them.
Bone pain, bone pain.
Actually, sir, bone pain is when there is a difference in when any movement will increase that kind of pain. That is bone pain. You know, any movement, if you are getting up in the morning, you will have huge pain. You know, and mostly when you assess the person, you will be able to understand that this is a bone pain, and then you do investigation, you find out.
How is it different from muscle pain or other pain, neuralgic pains?
The bone pain is always there. It is persistently, a dull pain will always be there, and with movement it will increase. That is how you differentiate between them.
So like I said at the outset, it's a very gnawing and a deep-seated pain, and like Ma'am said, it's going to be persistent. Differentiated from joint pains, musculoskeletal pains and other arthralgias and arthritis. You have to be very specific. Then people with depression also land up with generalized body ache, etc. So clinically and also asking him and repeatedly prodding him will lead you to a kind of a reasonable diagnosis.
So very simple. Multiple myeloma. Osteoclastic activity is more than osteoclastic activity. You have either skeletal survey or MRI or PET-CT. For example, sternum. If there is half of the sternum which has osteolytic lesion and the patient gets up from the sleeping position, you have pain. You have nothing else but osteoclastic activity taking over. So it's a combined radiological and clinical judgment where you come to bony pains. And you have to have that to understand. And that's why bisphosphonates has a different activity than rank ligand inhibitors like denosumab. Denosumab is a rank ligand inhibitor, while bisphosphonate is not a rank ligand inhibitor. And that is where you need to differentiate between the two.
Dr. Amit Vora, just two comments. As you were saying about art therapy, so is it like on the model of IS? They take poor people, they train them, make them say anti-people or whatever. Your own people, they will be terrorists. So they are making terrorists. So you are doing something like that. So terrorists against the cancer. So another point was about immunotherapy. Is it like using ED and CPI that is being used against opposition?
No, sir. It is not CPI, it is not ED. It is your own system. Restoring your own environment. I think you have asked a very right question, sir. The body ka homeostasis gets affected. Multiple diseases happen. What is diabetes? Diabetes is an autoimmune disorder. What is hypertension? It's an autoimmune disorder. Alzheimer's, myasthenia gravis, all are autoimmune disorders. Cancer, slowly is coming into that autoimmune disorders, and as a result, immunotherapy. आप सोचो सर 2011 में सबसे पहले इम्यूनोथेरेपी FDA अप्रूव था. 2023 में 89 cancers में immunotherapy is approved. Nowhere in the world, in 11 years time, 89 different cancers, immunotherapy is approved by all the government bodies of the world.
बहुत पहले का याद आता है कि autoimmune therapy was being used for some allergic phenomena. डॉक्टर प्राशर सर, आपने बहुत यूज किया मेरे ख्याल 40 साल पहले. तो
सर इतने ओल्ड नहीं लगते हैं, 40 साल पहले नहीं.
86 से प्रैक्टिस में.
मुझे 40 साल हो गए.
I would say that.
मुझे 40 साल हो गए.
So this is one of the things I tell my people, that you have been using anti-allergies for so long. Now allergy is not a useless thing. Allergy is actually a good thing for you. Allergy is surveillance in the body to detect any anti-cancer, anything which is circulating out of the way, and the body detects it and clears it. you are suppressing it unnecessarily just because your nasal secretions are more, and therefore you are actually risking yourself to the cancer. And this is actually coming true now that wisdom is gone.
You are so right, sir. 2019, the Nobel Prize which was there, 100 years back, exactly 100 years back, Dr. Cooley, what he used to do, sepsis में से pus cells निकाल के tumor cells पे inject करते थे, and they found that these tumor cells were in remission for a number of times. So you are absolutely exact. It took mankind 100 years to realize what Dr. Cooley did, and now they got the Nobel Prize.
Dr. Vora,
Dr. Kalra, sir, let him answer the
एक बात कहते हुए लेने दो मेरे को. मैं ये कहना चाहता हूँ कि जो अभी तक जो सब कहा है, जो इम्यूनिटी और एलर्जी की बात थी, वो डॉक्टर चौहान के लिए कह रहा हूँ. तुम एक बार मोहब्बत का इम्तहान तो लो. तो ये जो एलर्जी का उधर का एक इम्तहान होता है जो एक दूसरे को चेक करते हैं.
Physician वाला question. Chronic renal failure is a very high. The only exception is multiple myeloma. So as the chronic renal failure develops, do these patients develop hypocalcemia or the calcium generation overpowers?
You have asked such a wonderful question. The moment osteoclastic activity increases, calcium is released in the organ. So hypercalcemia, is one of the manifestation of multiple myeloma. But at the same time, within a very short span of time, patient develop hypocalcemia. Because you give denosumab, osteoclastic activity is suppressed. You give bisphosphonates, suppressed. You give cortisone, suppressed. It's a very fine balance between the two. And we sometimes get so perplexed. यार अभी तो calcium 12.1 था, अब साला 7.8 हो गया. One of the most important things which people forget even in ICU is corrected calcium.
Ionized calcium.
हमारे patients में hypoalbuminemia is so common, and people start giving calcium therapy without realizing corrected calcium में जरूरत ही नहीं है.
Thank you, sir.
I think I think we had a wonderful session. Although